So let me introduce the first speaker. He's Krishna Rao, who is with the Public Health Foundation of India in New Delhi. I do think most of him know you. Even as an external guy, I was very impressed by his 2010 publication, Why Some Doctors Serves in Rural Areas, his Chhattisgarh study, which is really quintessential. He kept on working in the same field. Last thing I remember was his August 31 editorial op-ed in The Hindu on the same issue. And today he will speak on just the same, again, how to attract health workers to rural areas, findings from a discrete choice experiment from India. Krishna, floor is yours.
Thank you very much. I'd like to start by saying that I'm really glad to be here for the second time for this conference. What I'm going to talk about today is at a point where Dr. Sundaraman left off, and that is he said that the numerical numbers are not so important in terms of how many doctors, nurses to produce, but how to address the distribution. And in my presentation today, I'm trying to bring some evidence to that. What sort of things might help us to address the rural-urban differences in the number of health workers, principally doctors and nurses. And the method that we have used to try and answer this question is called a discrete choice experiment. I'll talk more about both these things in detail. I'd like to start by first highlighting the extent of this rural deficit. So this graph here is from the 2001 census, and it shows the urban-rural differences, distribution of different categories of health workers. In general, what you find is that around 60% of your health workers, whether they are doctors, nurses, Ayush, or whatever, are located in urban areas of your country. And when you factor in the population levels, you see that this difference becomes even greater. So for example, you have 3.2 allopathic physicians per 10,000 population in rural India, but about 13 per 10,000 in urban India. That's about a four-fold difference. This difference is very starkly reflected in this table, which is data I collected when I was in Uttarakhand in 2010. And this shows in that one district of Almora the deficiency of doctors and nurses at PHCs. About half the PHCs in that district had no doctor, okay? And similarly for nurses. And in this mountainous area of India, there is no private alternative for getting clinical services, qualified private alternative. There were no qualified MBBS doctors in the private sector working in rural areas of this district. So the pressure on the challenge for the government to bring more qualified doctors and nurses to rural areas of India in situations like this is even more, because there is nowhere else people can go for getting services of qualified practitioners. So how do we address this gap? What can be done to bring more doctors and nurses, qualified doctors and nurses, to rural areas? And that is what our discrete choice experiment is trying to answer. We'll try and look at different types of monetary and non-monetary incentives and how they might, and what effect they have on attracting more of these doctors and nurses to rural positions. This study was conducted in 2010 in two states, in Uttarakhand and in Andhra Pradesh. These are two geographically diverse states, and both have their own types of human resource problems, but they also are very different in the production capacity of human resources. Andhra Pradesh has a lot of medical schools and nursing schools. Uttarakhand has very few. The study was done in two phases. There was a qualitative phase, I'll talk about this a bit, and there was a discrete choice experiment phase, which used information from the qualitative phase. Our sample was in-service doctors and nurses working at PHCs, and final year medical and nursing students at both public and private medical schools. So we had people who were in their final year in medical schools who would be entering the job market, and also people who are already in government service working at primary health centers in both these states. And our DC method, we used bivariate probit and mixed logit regression. I won't go into details of this so much. Okay, so our qualitative phase. The attempt of our qualitative study was to understand what job attributes are important for health workers in choosing a job. So we used semi-structured interviews, purposive sampling, and these were sort of vetted with some policy interviews. So we, as I mentioned earlier, we sampled both students and in-service people. And among students, there was medical, nursing, and Ayush students. Similarly for in-service clinicians working at PHCs. At the product of our qualitative study was, we ended up identifying 8 major attributes, right, that were important for health workers. And this means both medical students, final year medical students, and in-service doctors for choosing a job. So one was the type of health center, and there were 3 levels within that: clinic, a 20 to 30 bed hospital, a 50 to 100 bed hospital. Then there was area characteristics, which ranged from having a well-connected place, having good educational facilities for children, and good quality housing, to the opposite, which was located in a poorly connected place with bad education facility for children and poor housing provided. The third attribute was health center infrastructure. This ranged from a well-maintained building, adequately equipped with few shortages of drugs and supplies, to the opposite of that. There was a staff attribute, which ranged from fully staffed with moderate workload to the opposite, which was few staff and heavy workload. Then salary, this for doctors, it ranged from 30,000 to 80,000, and for nurses from 10,000 to 30,000. And the sixth attribute was change in location to city town. The one level in that was on completion of 3 years, a person could opt for a change to urban area of 3 years of rural service. To the second, which is what the norm is, that there was no certainty about having a transfer to a urban area after any amount of rural service. Then the seventh was professional development, and that included 2 options. One was short duration training courses versus the other one, which was easy admission to postgraduate education after 3 years of rural service. And this is what is the policy being practiced in Andhra Pradesh and several other states. And finally, the 8th job attribute was job location. And there were 2 levels in this. The job is located in the person's native area, and the other is that the job is not located in the person's native area. So these 8 attributes and levels were then translated into job choices. Okay, so if you notice this table here, the 8 attributes are in bold, and different combinations of levels within these attributes were used to create different job scenarios. And the person would be given 16 of these job choices, and they had to select whether they like job 1 or job 2. Okay, and then there was a second question to that, is whether if they were offered the job they selected, would they accept it. Okay, and so both students and in-service doctors and nurses were made to complete a questionnaire like this, in which they chose between different job scenarios. I'll skip over the sample size, but talk a bit about the sample characteristics before I go into the results. Most of our students were male. For medical students, most of our nursing students were female. Similarly, for in-service doctors and nurses. Rural upbringing was much higher among nurses than among medical students and doctors. Okay, so quickly the results. So this graph here shows the proportion of medical and nursing students who would select a rural job, okay, opt for a rural job, given these different characteristics. For example, if you look at the first bar there, for a salary of 30,000, we have about 18% of doctors who said they would take a rural job, compared to about nearly 80% of nurses, and so on and so forth for different attribute levels, right? So what are the few things that seem to stand out for this? One is that it didn't matter what you offered medical students, right? Those are the dark blue line. There was very little uptake among medical students for opting for a rural job, okay? But the story for nurses is entirely different. For nurses, a much larger proportion of them were willing to take up rural jobs for any of these different characteristics. The second thing I'd like to point out is that even among medical students where uptake of rural jobs was very low, PG reservation had the highest effect. Okay? Okay, can I get 2 minutes more? Yeah. And jobs in native area didn't have a big effect for medical students. If you come to in-service training, these are in-service doctors and nurses, what we find is that the uptake is much higher for both doctors and nurses. But here again, postgraduate reservation comes up to be the most powerful incentive for them to take up a rural post. Okay? But the contrast between in-service doctors, nurses versus medical students and nurses is quite stark in terms of their propensity to take up rural jobs. This graph here plots the incremental cost per worker that would be spent for each of these incentives, right? On the y-axis versus how many more doctors or medical students would take up a rural post. And I want to highlight two things here. One is, if we would plot just the salary increases and how many people, what proportion of the students and doctors would take up a rural post, what you find is that the supply of medical students for rural service is quite inelastic, and that is the red line, okay? Even increasing the salary from 40 to 80,000 didn't increase the proportion of medical students who would opt for taking up a rural job, okay? On the other hand, for in-service doctors, the supply was more elastic. There was a greater probability or proportion of in-service doctors who would take up rural posts if salaries were increased much more, okay? So once you get into government service, salary can play an important incentive in getting doctors into rural posts. But to get your cohort of medical students into government service and rural posts, salary has a very small effect. If we looked at cost effectiveness of these different interventions, what comes out is that the PG reservation policy is the most cost-effective intervention. And that is because there is very little investment on the part of government to implement this incentive, okay? There is nothing they have to do really except reserve some seats within medical colleges. So that is, but the effect of that is tremendous on the uptake of rural jobs. So it becomes a very cost-effective option. So finally, my concluding points is that incentivizing medical students is extremely difficult, okay? And among these, the possible incentives one can have, PG reservation seems to be the one that has the most effect. On the other hand, incentivizing nursing students, in-service doctors and nurses is much more possible, okay? And even within this, the PG reservation incentive is very powerful, along with many other things. Single incentives are much more powerful than, packages of incentives are much more powerful than single incentives. In India, we've pretty much always thought about incentivizing using single incentives, like increasing salary or providing better housing. But these really need to be packaged to be even more effective. And finally, for UHC, it's important to address this rural deficit, because it doesn't matter whether you're going the insurance route or you're trying to strengthen the public sector. If you don't have enough health workers in your rural areas, there's no way that you could ever achieve universal health care or even come close to it. And to achieve that, the PG reservation policy seems to be something that can be a powerful way of addressing this gap, though it also has its problems. On the other hand, one should be even more open-minded and think about whether we can use nurse practitioners or non-physician clinicians who have a greater propensity for rural service rather than just looking for medical graduates or doctors. Okay, Thank you.
Thank you, Krishna Rao.